long. And we are here to talk public option today. So folks who are following along at home, we had a big step forward last year when we passed a bill to set the ball rolling to move towards a public option. And so the making changes to the healthcare system are big and complicated, and we needed to make sure that we had done the analysis to be able to structure a program right. And so we've done that. We had back in earlier this month, the beginning of February, we had a actuarial report come back from the Department of Commerce and Minnesota Department of MBH. And we are now doing the hard process of digging into those numbers and trying to figure out what the best plan is to move forward. But I want to zoom out and just remind us all why we're here. And that's because too many folks in Minnesota right now can't afford healthcare or can't use the healthcare they have. And we've heard along the way when we had the bill up in our committee hearings last year, and in the interim, when many of us have traveled around the state and listened to communities and listening sessions on the public option, and we've heard time and time again really heart-wrenching stories from individuals who are on healthcare that they can't use because the deductibles are $7,000, $8,000, $10,000, and so essentially only catastrophic coverage, which means people are delaying care and getting sicker and having worse results. Or they're part of the still far too many Minnesotans who are uninsured, either because they can't afford insurance or because they don't want to buy useless insurance. And so that's the challenge that we're trying to solve. And we're trying to do that in a way that is uniquely Minnesotan, which is building on MinnesotaCare, which has been a hugely successful bipartisan program that we've had in the state for the last several decades. And this is an option that we have in Minnesota that no other state has, really, to be able to use a program like that and build out access with a stable existing program. So we are digging in deep with our agencies right now and working through the report and the numbers, and we hope to have Bill soon to be able to introduce and work through the next steps. But this year is the year to get this done. We know that even if we pass it this year, it's a long road ahead until we would have access for Minnesotans. It would take time to get a federal waiver. It would take time to set up the program. And under the bill we have right now, it would be 2027 when the program is rolled out fully. So we want to make sure that we're getting this started because we know Minnesotans can't wait to have access to healthcare that they can use and afford. And with that, I'll turn it over to our first speaker, who is Wendy Sivanich with ISA. Hopefully I said that.
Good morning. My name is Wendy Sivanich. I'm a small business owner in Northfield at a CPA firm where I primarily work with small businesses. I'm a leader with the Rural Organizing Project of Isaiah, Minnesota. My husband and I receive our health insurance through my husband's employer. They used to have a small group plan, but that became unaffordable when one individual in the group experienced an expensive health event. To control their costs, the employer switched to an ICRA, an individual coverage health reimbursement arrangement. While that ICRA stabilized his employer's costs, it forced us to find our own private insurance in the marketplace. Even with the use of a third-party provider who was supposed to make the process easy, my husband spent hours online and on the phone trying to understand our plan options, getting enrolled and then trying to decipher the flood of mail that came to our mailbox in the ensuing months. We are both reasonably intelligent and educated individuals whose first language is English, yet we still don't have a clear understanding of our health insurance coverage, other than that the premium is more expensive than it was before. We now have to pay for the premium with after-tax dollars, and we are each on the hook for a $7,500 deductible, and that is before anything other than preventative coverage is covered. Even that coverage has proven questionable in our experience. We think twice before going to the doctor when we might be sick, and we regularly pay for visits with cash to bypass our insurance altogether because the provider will charge less if they don't have to deal with health insurance. I actually fear the day that one of us might be diagnosed with an illness requiring extensive care, and we would have to navigate the complexities of referrals whether we are in network or out of network, and having to make innumerable phone calls. Our health insurance system is broken. It limits people's choices, it's too expensive, and it's too complex. In my work, I see individuals having to make choices about the work they choose to do and even how much they work, based on their health insurance. I see employers who can no longer provide affordable, comprehensive insurance because it's too expensive, forcing employees to navigate the exhaustingly confusing marketplace to obtain their own insurance. I have multiple clients with employees who are requesting to work less hours, not because they want or need to work less, but because they need to limit their income to make health insurance affordable. One of these employees is being treated for cancer and has high-cost medical needs. And in her words, "I need to keep my insurance right now more than I need to work." Another employee is just married and would like to have a baby, but currently has no health insurance. They have requested to work less hours so that they may be able to afford insurance in the marketplace. We need a public option that is affordable to employers and individuals, that provides comprehensive coverage beyond just a high deductible plan, and it needs to be simple enough to navigate that it does not feel like a full-time job to do so.
Well done. Wow. Yes.
Hi, my name is Cindy Vanderpool. As a farmer and a small business owner, I'm here to share my strong support for establishing a public option. This work would make a big difference for our family and our farm business and our rural communities. Together with my family, I operate Pastures of Plenty Farm in Kirkhoven, Minnesota. We raise and market sustainable raised hogs and beef cattle. You might have seen our product at Mississippi Market if you shop there. As a farmer and an independent employed person, I often struggle to find affordable coverage. So we are always waiting for that other shoe to drop. Since I first testified on the public option in past sessions, it did. I was diagnosed with breast cancer and underwent 2 surgeries, 33 rounds of treatment for radiation in 2021 and 2022. Thankfully, when I was diagnosed, our income was low enough that I could access coverage through MinnesotaCare. If it wasn't for that coverage, the news would have been financially devastating for our family and our farm. I've driven to the Capitol to work on this issue for many years, including through my cancer treatment. I feel so strongly about it because the status quo isn't working for too many of our family farms. I've experienced MinnesotaCare, and I know it to be quality and comprehensive coverage that I can afford to use. As a small business, I can't afford to pay the premiums on the individual market only to find out that I owe that much more in deductibles when I'm sick and need care. And unfortunately, that reality today I'm facing. We were kicked off of MinnesotaCare last month. I look forward to the day when we have the option to pay our own way into MinnesotaCare so that we're not pushed off the plan that works for us because we've earned too much money. Thank you for your time.
Thank you.
Kate Lynch.
Sorry about that. My name is Kate Lynch. I'm an LPN at Health Partners and a member of SAU Healthcare Minnesota and Iowa, the healthcare union of 50,000 workers across the state, and we proudly support this bill. Currently, too many of my patients are forced to buy high-cost private health insurance plans, with many buying their insurance on MNCare. It's time they are able to access a true public option in MinnesotaCare to help make healthcare more affordable. Too often, caregivers like me watch our patients delay or skip necessary medical care because they can't afford the high out-of-pocket expenses. And every day, people call in about serious health issues, and we recommend that they come into the clinic so we can better diagnose or treat the issue. So many respond, "I can't afford the copay," or "my deductible is too high." My patients with MinnesotaCare don't face that awful choice, and this will help expand that. I'm not just here as a caregiver, I'm also a concerned mother. I have 2 adult sons, Martin and Jack, who are respectively 25 and 21. Currently, they are both covered by my health insurance plan, but soon they will age off my plan, and I worry they won't be able to afford good health insurance. What if under the current system, they're tempted to skip care to save money or can't afford to treat an illness? This fear is very real for me. Fellow SEIU member James Holt Jr. lost his son Alec when he aged off his parents' health insurance plan and died because he had to ration his insulin. A true MinnesotaCare public option will mean parents like me can sleep a little easier knowing that our children will more likely have access to quality, affordable health care insurance.
Good afternoon. Mi nombre es Fabiola Martínez y soy una líder de Unidos Minnesota y soy la fundadora y co-director de la Red Latina de Educación Temprana MN. Yo apoyo la opción pública.
My name is Fabiola Martinez de Estrada. I'm a leader with Unidos MN and co-founder and co-director of the Latina Network of Early Childhood Education. I support public option.
La Red Latina es una organización comprometida con el bienestar y el desarrollo de las mujeres que proporcionan cuidado infantil en hogares. Hoy quiero destacar la importancia crucial de proporcionar un seguro médico de calidad a las educadoras de cuidado infantil.
La Red Latina is an organization committed to the well-being and development of women who provide childcare in their homes. Today, I want to highlight the crucial importance of providing quality health insurance to childcare educators.
Al igual que nuestra lucha por la justicia social, donde nos unimos el año pasado para ganar MNCare Immigrants Conclusion. Es esencial que sigamos reconociendo la necesidad de cuidar a aquellos que cuidan en nuestros niños y seguir expandiendo el acceso.
Just as in our fight for social justice, where we joined together last year to win the MNCare Immigrant Inclusion, it is essential that we continue to recognize the need to care for those who care for our children and continue to expand access.
Estos profesionales desempeñan un papel fundamental en desarrollo y bienestar de nuestras futuras generaciones. Seguimos celebrando la victoria del acceso a MCare sin importar el estatus migratorio, pero tenemos que seguir luchando para crear un entorno más saludable para nuestros niños y las generaciones futuras y seguiremos luchando para que más personas califiquen.
These professionals play a fundamental role in the development and well-being of our future generations. We continue to celebrate the victory of access to MNCare regardless of immigration status. But we have to keep fighting to create a healthier environment for our children and future generations and ensure that more people can qualify.
Proporcionar un seguro médico integral no es solo un acto de justicia, sino una inversión en la salud y el bienestar de quienes forman la base de la educación infantil. Al cuidar a quienes cuidan, no solo fortalecemos a estas valiosas profesionales, sino que también construimos una sociedad más fuerte y comprometida con el bienestar de todos.
Providing comprehensive health insurance is not only an act of justice, but an investment in the health and well-being of those who form the foundation of early childhood education. By caring for those who care, we not only strengthen these valuable professions, but also build a stronger society committed to the well-being of all.
En el sistema actual, muchas de estas educadoras enfrentan barreras para acceder a la atención médica que necesitan.
We must recognize that in the current system, many of these educators face barriers to accessing the medical care they need.
Las desigualdades en el sistema de salud que hacen que sean aún más difíciles para obtener un cuidado adecuado. Es por eso que debemos seguir luchando por opciones de atención médica pública como MNCare, opción pública, para garantizar que todas las educadoras de cuidado infantil tengan un acceso a la atención médica que merecen.
Inequalities in the healthcare system make it even more difficult for them to obtain proper care. That is why we must continue to fight for public healthcare options such as MNCare Public Option to ensure that all childhood educators have access to the medical care they deserve.
Juntos podemos crear un futuro donde todas las mujeres que cuidan a nuestros niños sean apoyadas y valoradas como se merecen. Tenemos mucho trabajo por hacer y nuestras familias no pueden esperar. Necesitamos un apoyo opcional, opción pública ahora. Gracias.
Together, we can create a future where all women who care for our children are supported and valued as they deserve. We have a lot of work to do and our families cannot wait. We need a public option now. Thank you.
Good afternoon. I'm Melissa Wiklund. I'm Chair of the Senate Health and Human Services Committee, and I'm Chief Author of the MinnesotaCare Public Option proposal. I want to thank all of the storytellers who spoke today, and the countless number of Minnesotans who have come to committee hearings. They've been speaking out in town halls. Just had a town hall in my district last weekend. And Minnesotans are telling us that this work to implement a public option is absolutely essential. We know that the need for affordable, trusted public option is urgent, and that our whole state benefits when people have access and can afford the health care that they need. As Representative Long alluded to, passing a public option is a process, and it does take analysis on top of work to develop a bill and the fiscal note along with that. We're excited to have the additional information that comes from the report that was produced by the Department of Commerce. And so we can get going on doing that analysis and bill development. Minnesotans have made it clear that expanding access to affordable health insurance is a priority, and it is a priority to legislators as well. A lot of work has gone into creating the MinnesotaCare Public Option to this point, and there's a lot of work yet to do in this session. But I am confident that we will get it done. So thank you, and we will now take questions.
Senator, could you stay up there and can you talk about some of the financial aspects? What are the price points? What different decisions might you make that affect the dollars and the reimbursement rates and things like that?
Well, the report came back with, we requested them to develop different options for us to examine. So we have two different models to be working from, and those have been broken down by the rates that could be paid and about different parameters relating to the tax credits that were subsidization that we would do. So we're looking at all of those variables within each model to understand whether we are in support or favor one approach over another. Factors that we're looking at are certainly the amount of federal reimbursement. It depends on some of the choices we make, how much that we feel that we would be able to commit as a state, and then looking at affordability for people who are wishing to buy into the program. It needs to be affordable for them as well.
And reimbursement rates?
And the reimbursement rates are another consideration. The models have used two different choices. One would be like staying with the current public program rates, and the other would be moving to a MNCare rate. They picked two. I mean, there's many permutations, but those two options do give us a lot of information about costs and what we would be looking at.
Have you talked at all about MNCare reimbursement rates?
That is the second.
Okay, I thought I heard you say MNCare. You said Medicaid, you said Medicare.
Yeah, there's two scenarios that use our current public program rates, Medicaid rates, and then two that use the Medicare rates.
Realizing that you've got a lot of pieces of the puzzle here and a lot of moving parts, do you have a cost range of what this might end up costing the general fund?
Take the time.
Which
Yeah.
biennium?
So the study has these two models and then four options in each model, and there's a different range for each of those. So it's between $100 million and $300 million a year, depending on which choice you make. Obviously, if you're reimbursing at a higher rate, it's going to cost a little bit more. If you're not limiting some of the tax credits and other support, that would cost a little more. There is a premium scale that's built in and assumed, but that could be toggled. So there's a lot of ways that we could adjust it to try to get to a number that we can afford. But I think the top line for me is that the report says this will help between 100,000 and 150,000 Minnesotans a year, depending on which option you choose. And a number of those folks are people who are currently uninsured, but the bulk of those folks are individuals right now who are on individual market plans that are in these extremely high deductible bronze plans where they really aren't able to access care.
Have you identified a revenue source for the subsidies?
So we have different options we're considering. We're waiting to see, of course, what the February forecast comes back with. And we're in conversations with our Ways and Means Chair and Finance Chair and trying to figure out what the possible options are. I think it's a little bit of a chicken and the egg. We have to know a bit what our target is before we know how to toggle some of the pieces that we're adjusting. But we set this ball in motion last year for a reason, and that's because we know that this is really important work for the state. This has been a high priority for Democrats for many years. It was in the governor's budget for several years as well, a public option. So we're committed to getting this done and finding a path forward.
You mentioned that you wanted a uniquely Minnesota option, which seems to indicate that you're more in favor of expanding MinnesotaCare. I think you even said building on MinnesotaCare rather than the second scenario, which is having a mandated qualified plan on the insurer. So have you narrowed it down to that, to just expanding MinnesotaCare?
I think it's fair to say that is certainly my preference. I'll let Senator Wiklund speak for herself, but I think that is the plan that we proposed last year was to expand MinnesotaCare, and we think that is a way to build on a proven, trusted plan that I think folks spoke to their experience with. What we've seen other states do is more of the QHP model. So we would be the first state in the country to be able to build on a plan like MinnesotaCare if we went that direction.
I think I'd say I generally support the first model. I think that there are a number of concerns that I have with the second model, and but the reasons that Representative Long gave for supporting the Model 1 are in alignment with what I'm thinking. So what we're working on right now.
Majority Leader, not a lot of states have done this. Does it hurt not to have a lot of states to point to and the experience they've had with this?
Well, no state had done MinnesotaCare when we set out to do that in '92, I think. And so we were really path breakers there, trying to fill this gap of folks who were making too much to get access to Medicaid, and what could we do for folks who still couldn't afford access to care. But that has a cliff. There's an income cutoff. It's about $50,000 for a family of four. And so we know that there's a lot of folks who make more than that. We see the incentives that creates to have people suppress their income to try to stay on healthcare, which isn't good for our economy or for those individuals' families. So we're trying to figure out a way to deal with this continued problem where we still have a big chunk of folks in Minnesota who can't afford care, or who have care they really can't use. And so I think it's good for Minnesota to be a leader in this space, and I think we will be.
Is it fair to say you're going to wait until the February forecast before deciding on approach, given the money question?
I mean, I think right now, this week we're trying to take the information from the report, really dig into what are some of the key decisions that we would have to make as policymakers to try and shape a bill, and I think that we have a lot of things that we can do to work on that. I think some of the financial part, the revenue part, yes, we have to wait, but I think there's a lot we can do, and we're working on right now.
Could you do the calendar for me? 27 would be the next biennium, within the next biennium, or would it be 2 bienniums out?
Kind of the end of the second part of the next.
So it'll be the last year of the budget window would be 2027. And that's just simply because we have a federal waiver to do a basic health plan for MinnesotaCare. You can only have one waiver at a time. We are going to have to reapply for a modified waiver if we move forward with this. That would happen over the summer, could take up to a year or more, depending on how fast the federal government processes that. And then once that gets approved, you can start the process of setting up the program. So there is some time to develop the program that's required, which is why even last year we'd set out 2027 as the year of implementation.
not to belabor the process part of it, but just to get into the nuts and bolts of that. So don't you have to pick a model to then write the bill, to then order the fiscal note, to then apply for the waiver? So like how, but you mentioned the chicken and the egg, that you have to see the financial. So just help me understand what the process is of what you're doing this year.
Yeah, I'll take a crack. So right, we are going to have a bill. We are going to have to pass a proposal. The chicken and the egg I mentioned was just figuring out what our revenue is available, because that'll determine some of the toggles that we might choose. But I think that we will have a proposal. We're hoping that that'll pass this year, and then that would kick off the process of authorizing application for a federal waiver and moving forward at that level. All right. Thank you all.
Thank you.
Thank you.